Now today's topic is prolonged labor and the obstructed labor. First, what is malposition? Malposition refers to an position of the vertex other than the flex anterior one. Occipital-posterior position. In a vertex presentation where the occiput is placed posteriorly over the sacroiliac joint sacrum called the occipito-posterior position. Occiput placed over the right sacroiliac joint known as the right occipito-posterior. If it is placed over the left, then it is known as the left occipito-posterior, traditionally called the third or fourth position of the vertex. Occiput placed over the sacrum called the direct occipito-posterior. All three positions are primary or secondary. Primary means developing before the onset of the labor, or secondary developing after the onset of labor. In majority of the cases, anterior rotation of the occiput occur and follows the course like that of an occipito-anterior position, and it is favorable position. But as a posterior position occasionally gives rise to dystocia, it is described along with the malposition. This is a presentation of the right occipito-posterior left incidence at the onset of labor about 10%. Incidence is about 10%. Expected to be more during the late pregnancy and less during late second stage of the labor. Right occipito-posterior is 5 times more common than the left occipito-posterior. Dextral rotation of the uterus and the presence of the sigmoid colon on the left disfavor the left occipito-posterior position. Dextral rotation is the movement or the move rotation to the right clockwise, and opposite is the levo rotation. Causes: shape of the pelvic inlet. More than 50% of the cases are associated with the anthropoid or the android pelvic. The wide occiput are comfortably be placed in the wider posterior segment of the pelvis. Fetal factors: mark deflection of the fetal head due to the high pelvic inclination, anterior attachment of the placenta, primary brachycephaly. High pelvic inclination of the brim is higher, and the upper sacrum is relatively vertical and the convex. Occiput will be placed to the posterior surface, anterior attachment of the placenta, well flexed attitude, but convexity of the maternal and the fetal spine is opposite, which leads to the deflections of the fetal head, and thus the occiput with occupy the posterior part. Primary brachycephaly flattened area at the back of the skull diminishes the effective movements of the flexion. This is the alignment. Uterine factor: abnormal uterine contraction which may cause or effect lead to the posterior persistent deflection of occipito-posterior position. Diagnosis: abdominal examination. On the inspection, abdominal looks flat below the level of the umbilicus. Umbilical grip: fetal limbs are more easily palpable near the midline on either side. The fetal back is felt far away from the midline on the flank and often difficult to outline clearly. Anterior shoulder lies far away from the midline. Pelvic rib: head is not engaged, sensibly not felt as in the well-flexed posterior position. Auscultation: intensity of the fetal heart sound felt on the flank and often difficult to locate. Vaginal examination: elongated bag of membrane which is likely to rupture during the examination. Sagittal sutures occupies any oblique diameters of the pelvis. Posterior fontanelle felt near the sacroiliac joint. Anterior fontanelle felt more easily because of the deflection of the head, lower than the posterior fontanelle. This is how the vaginal examination in post occipito-anterior position in the well-flexed head, posterior fontanelle easily felt, but in occipito-posterior position, anterior fontanelle is felt. Now the mechanism of labor. In favorable condition, flexion, interrotation of the head, 3/8 anterior shoulder and 2/8. Occupy head rotate by the 3/8 of the circle and the shoulder is rotated by the 2/8. Occupy the right oblique diameter in ROP and left oblique diameter in IOP. Further descend as occipital anterior position, restitution, external rotation, both of the shoulder and trunk. But in favorable condition, incomplete forward rotation will lead to the deep transfer arrest, non-rotation or the mal-rotation. This is a presentation in the right occipito-posterior. If it is favorable, then there will be the long rotation of the head that put the occiput behind the pubic symphysis. If there is a short rotation by the 1/8 of the circle, and it may put the occiput behind the sacroiliac joint. And unfavorable non-rotation, that it will remain static, it will not rotate. And there will be the short posterior rotation. Mechanism of phase to pelvis delivery: further descent occur until the root of the nose. Flexion occurs, restitution, external rotation, persistent occipital posterior. Management: early diagnosis, watchful expectancy for the descent and the anterior rotation. Early cesarean section anticipating prolonged labor. No progress of labor, persistent deflection and non-rotation. Arrest labor, incoordinate uterine contraction, fetal distress. Management of the arrest occipital posterior position. Arrest in transverse oblique occipital posterior position. Ventouse or alternative method like manual rotation or extension on cesarean section, craniotomy. Occipital sacral arrest. Forceps application followed by the extraction as phase to pelvis delivery. Liberal medial lateral episiotomy should be done. Deep transfer arrest. The head is deep into the cavity. Sagittal suture is placed in the transverse bispinous diameter and there is no progress in descent of the head even after the 0.5 to 1 hour following full dilatation of the cervix. Causes are the pelvic structures, deflection of the head, weak uterine contraction, laxity of the pelvic floor muscles. Diagnosis: head is engaged, sagittal suture lies in transverse bispinous diameter, anterior fontanelle is palpable, faulty pelvic architecture. Management: if the vaginal delivery are not safe, cesarean section is done. If vaginal delivery are safe, ventouse, manual rotation, forceps rotation. It should be done by the skilled and expertise person. Manual rotation of the occipital posterior position. Manual rotation can be implemented with the whole hand or with the half hand method. Step: put the patient under anesthesia, provide lithotomy position, maintain full surgical assistance. Catheterization should be done. Identify direction of the occiput by the per-vaginal examination. Whole hand method: gripping of the head. In the ROP or ROT, the left hand, and the LOP or LOT, in left position, right hand is usually used. The corresponding has is introduced into the vagina in cone-shaped manner after separating the labia by the two fingers of other hand. In occipital transverse position, the four fingers are pushed into the sacral hollow to be placed over the posterior parietal bone, and the thumb is placed over the anterior parietal bone. The oblique posterior position, the four fingers are partially supinated and are placed over the occiput, and the thumb is placed over the sinciput. Slight disimpaction may be needed for the good grip. By the movement of the pronation of the hand is rotated to bring the occiput anterior along the shortest route. Simultaneously, the back of the fetus is rotated by the external hand from the flank to the midline. This is an essential prerequisite for anterior rotation of the head. A little over rotation is desirable, anticipating slight recurrence of malposition before the application of the forceps. In the alternative method, the four fingers of the pronated right hand are placed over the sinciput and the thumb over the occiput in ROP. As shown in the picture, the head is rotated in the supination movement of the head. Application of the forces. Following the rotation, when the right hand is placed over the left hand of the pelvis, left blade of the forceps is introduced. When the left hand is used, it is placed on the right side of the pelvis after the rotation. As such, the right blade is to be introduced first and the left blade is then to be introduced underneath the right blade. While introducing the blade, it is preferable that an assistant fixes the head by suprapubic pressure in a manner of the first pelvic rib. As it is the mid-forceps application, excess tension device should be used. Difficulties: failure to grip the head adequately due to the lack of space, failure to dislodge the head from the impacted position, inadequate anesthesia, wrong case selection. Dangerous: accidental slipping of the head above the pelvic brim and the prolapse of the cord. It is better to be performed cesarean section in such conditions. Half hand method. The rotation is done only by using the right hand. The four fingers are introduced into the vagina and tangential pressure is applied on the head at the lever of diameter of the engagement. The pressure is applied on the side and the parietal eminence of the head. In ROP and the ROT position, the fingers are placed anterior to the head and the pressure is applied by the ulnar border of the head. In LOP or LOT, the fingers are placed posteriorly and the pressure is applied by the radial border of the hand. The force is applied intermittently till the occiput is placed behind the symphysis clavus. This is a pictorial presentation how the half hand method is used. The management of the occipital posterior position. First of all, the early diagnosis is required. Careful monitoring in judicial and timely intervention. Watchful expectancy, oxytocin augmentation if required can be given, and the case has to be assessed in the early second stage. Anti-rotation of the occiput occur, then there is that occurs in 90% of the patient, then spontaneous ventrous or forceps delivery can be performed. If there is a persistent occipital posterior position, then assess the pelvis, causes of failure of anterior rotations or the malrotation, and the fetal status. If partial anti-rotation, there are the chances of deep transfer arrest. Non-rotation oblique transfer arrest, assisted delivery is required. Pelvis is adequate ventrous Ideal method is the ventouse or the forceps deliveries, manual rotations and the forceps application, forceps rotation and the delivery only by expert with the key length. If the pelvis inadequate cesarian section has to be malrotation, occipital posterior position, spontaneous face to pelvis delivery. If any delay or any side effect occur, then immediate cesarian section. This arrest and descent station of the head above the level of the ischial spine, cesarian section below this patient ischial spine, ventouse or the fourth forceps with deep episiotomy. Now the breech presentation. In breech presentation, the lie is longitudinal and the podalic hole present at the pelvic rim. It is the most common mark presentation. Incidence is 20% at 28th week, 5% at 34 week, 3 to 4% at term. Varieties, it may be complete, incomplete, breech with extended legs, footling presentation, knee presentation. Clinical features uncomplicated, complicated. Complicated are the prematurity, twins, contracted placenta previa, etc. This is a presentation of the complete breast footling presentation partial. Ectology prematurity is the most common cause. Factor preventing the spontaneous version, breech with extended legs, twins, oligohydramnios, congenital malformation of the uterus, such as septate or the biconate uterus, short cord, intrauterine death of the fetus, favorable adaptation, hydrocephalus, placenta previa, contractor pelvis, cornofrontal attachment of the placenta, undue mobility of the fetus, hydramnios multiparous, fetal abnormality, chromosome abnormality, trisomies like 13, 18, 21, anencephaly, myotonic dystrophy due to the alteration of the fetal muscular tone and the mobility. Now the diagnosis, complete breech and the frank breech. In the complete breech, fundal grip will shows the head suggested by the hardened globular mass. Head is palatable. Lateral grip, fetal back is to one side and the irregular limbs on the other side. Pelvic grip, breech suggested by the soft, broad, and the irregular mass. Breech is usually not engaged during the pregnancy. Fetal house are located high level about around the umbilicus. On vaginal examination, complete with soft and irregular parts are felt through the corners. During labor, palpation of the ischial tuberosity sacrum and feet at the side of the buttocks. The foot felt is identified by the prominence of the heel and the lesser mobility of the great toe. Frank breech, in frank breech, on the fundal grip, the head is palpable. Irregular small parts of the feet may be felt by the side of the head. Head is non-palatable due to the splinting action of the legs on the trunk. Now, in the lateral grip, irregular part are less felt on the side. In the pelvic grip, small, hard, and the conical mass is felt. Breech is usually engaged in the pelvic grip. Fetal horizon, it is located at a lower level in the midline due to the early engagement of the breech. Now, the vaginal examination, hard feel of the sacrum is felt, often mistaken for the head. For palpation of the ischial tuberosity, anal opening, and the sacrum only. Now, to confirm the diagnosis, ultrasonography has to be done to detect the fetal congenital anomalies and the congenital of the uterus to know the type of the breech. It measures the biparietal diameters, gestational age, estimated weight of the fetus, help in the localization of the placenta, AFI can be measured, and the attitude of the head. Now, the position sacrum is the denominator of the breech. First position is the left sacro-anterior, most common position. Second, right sacro-anterior. Third is the right sacro-posterior. Fourth is the left sacro-posterior. Mechanism of the labor, sacro-anterior position. Buttocks engaging diameter is bitrochanteric descent of the buttocks, internal rotation of the anterior buttock, further descent and the lateral flexion of the trunk, delivery of the trunk and the lower limbs follows. Restitution occurs so that the buttocks occupy the original position as during the engagement in oblique diameter. Shoulder bisectional diameter engages, descent through the internal rotation of the shoulder. Delivery of the posterior shoulder followed by the anterior one is completed by the anterior flexion of the delivered trunk, restitution and the external rotation. Head engaging diameter of the head is suboccipitofrontal. Descent with increasing flexions occurs. Internal rotations of the occiput occur anteriorly through the 1/8 or 2/8 of the circle, placing the occiput behind the pubic symphysis. Further descent occur until the subocciput hinges under the symphysis pubis. Head is borne by the flexion, chin, mouth, nose, forehead, vertex, and the occiput appearing successively. Sacro-posterior position. The head has to rotate to the 3/8 of the circle to bring the occiput behind the symphysis pubis. Now, the prognosis of the vaginal breech delivery, maternal risks include the trauma to the genital tract, operative vaginal delivery like episiotomy, forceps, cesarean section, sepsis, and anesthetic complication. Fetal perinatal mortality ranges from 5 to 35 per thousand birth, the overall perinatal mortality in breech still remains 9 to 25% compared with 1 to 2% for non-breech delivery. Factors which significantly influences of fetal risk are skill of the obstetrician, weight of the baby, position of the legs, types of the pelvis. Diagnosis of the dangers to the baby or complication, fetal complications for the breech. IUD, intrapartum hemorrhage, injury to the brain or the skull, birth asphyxia due to the cord compression, retraction of the placental, premature attempt at the respiration, delayed delivery of the head, cord prolapse, prolonged labor, birth injuries like hematoma, fracture, visual injury, nerve injury, congenital malformation. Preventions of the fetal hazard. The incidence of the breach can be minimized by the external cephalic version where possible. If the version fails or is contraindicated, delivery is done by elective cesarean section. Vaginal breech delivery should be conducted by the skilled obstetrician along with an organized team consisting of a skilled anesthetist and a neonatologist. Vaginal manipulated delivery should be done by the skilled person with utmost gentleness, especially during the delivery of the head. Antenatal management, identifications of the complicated factor, external cephalic version if not contraindicated, formulation of the line of management if the version fails or is contraindicated. External cephalic version, the success rate of version is about 65%. Time of the version, it should be done considered at or around 37 weeks. Contraindications are antepartum hemorrhage, fetal cause, the hyperextension of the head, large fetus, congenital malformation, dead fetus, fetal compromise, multiple pregnancy, ruptured membranes, known congenital malformation of the uterus, abnormal CTG, contractile pelvis, previous cesarean section, obstetric complications, oligohydramnios, old age, old primary gravida, bad obstetric history, severe preeclampsia, obesity, RH, isoimmunization. Now, the benefits of the external cephalic versions are reduction in the incidence of the breech presentation at term, reduction in the incidence of the breech delivery and the associated complication, reduction in the incidence of the cesarean delivery by 5%. Successful version is likely in cases of complete breech, non-engaged breech, sacroanterior, adequate like a non-obvious patient. Causes of failure of version, breech with extended legs, scanty leg, big size baby, obesity, short cord, uterine malformation. Dangers, premature onset of the labor, premature rupture of the membrane, placental abruption and the bleeding, entanglement of the cord, increased incidence of the fetal-maternal bleed, amniotic fluid embolism. Management if the person fails or is contraindicated. The assessment of the case is to be done, age of the mother, especially in primary gravida, associated complicating factors, size of the baby, pelvic capacity. USG examination is a gold standard for the decision making. Two methods of delivery can be planned to perform an elective cesarean section to allow spontaneous labor to start and the vaginal delivery to occur. Elective cesarean section. The indication of the cesarean section in the breech are big size, big baby, estimated fetal weight greater than 3.5, small baby less than 1.5, hyperextension of the head, stargazing fetus, footling presentation, risk of the cord prolapse, suspected pelvic contractions, or the severe IUGR, any associated complications, the overall incidence is in section breech ranges from 15 to 50%. Vaginal breech deliveries criteria to be fulfilled. Average fetal weight, flex fetal head, adequate pelvis without any other associated medical or the obstetric complication, availability of the facilities for the emergency cesarean section, availability of the anesthetist and neonatologist, facilities for the continuous labor monitoring, preferably electronic, and presence of obstetrician experience with the breech vaginal delivery. Now, the management of the vaginal breech delivery. First, a vaginal examination is indicated at the onset of labor for the pelvic assessment, soon after the rupture of the membrane to exclude the cord prolapse. And IV line is started with the ringer lactate solution. Oral intake is avoided. Blood is sent for the grouping and the cross matching. Adequate analgesia is given. Epidural is preferred. Fetal status and progress of labor are monitored. Oxytocin infusion may be used for the augmentation of the labor. Indication of cesarean section. Cases seen for the first time in labor with the presence of complication. Arrest in the progress of labor. Non-reassuring epiches, cord presentation, and the prolapse. Second stage is there the three methods of vaginal delivery: spontaneous expulsion of the fetus occurs with very little assistance. This is not preferred. Assisted breech, the delivery of the fetus is by the assisted from the beginning of the head to the end. It is usually employed in all the cases. Breech extraction partial when part of the entire body of the fetus is extracted by the obstetrician. It is rarely done these days as it produces a trauma to the fetus and the mother. Indication of delivery of the second twin after the IVP, cord prolapse, extended legs arrested at the cavity or at the outlet. Now, the scheme for the management of the breech presentation. Antenatal, this is a pictorial presentation that have been explained previously. Assisted breech delivery lithotomy position is given to avoid the udder cover compression. Antiseptic cleaning given. Potential block is given if required. Episiotomy on the climbing of the perineum. Or the while during the delivery of the breech head. Patient is encouraged to bear down. Soon after the trunk up to the umbilicus is born, the following are to be done. The extended leg and frank breech are to be decomposed by the pressure on the knees, popliteal fossa in a manner of the abduction and flexion of the thighs. The umbilical cord is to be pulled down. If the back remains posteriorly, rotate the trunk to bring the back anteriorly. This is how the delivery of the extended leg and abduction of the knee is done. Now the delivery of the arm. The whole of the fetus is held in the hand and pulled upward, and with the finger is hooked up in the axilla, and the head is rotated, pulled is out. Now the delivery of the upcoming head, Burns Marshall method. The baby has to be hung down so that the head get pulled down till the nape of the neck by the weight of the baby. Then both the head legs are grasped by the other hand, and it is rotated over through the 180-degree over the maternal abdomen, or by the forceps. Can be used. Killing forceps are used for the breech head delivery. Malar fraction and the traction modified Mercer Smith method. Management of the complicated breech delivery. Delay in the descent of the breech. Arrested at the outlet. It big size baby with extended leg, weak uterine contraction, rigid perineum, outlet obstruction, contraction. Management: if the outlet is contracted or the baby is big, cesarean section is to be done. In the absence of outlet contraction, fetal pelvic distortion, liberal episiotomy, and the fundal pressure with or without groin traction. Arrest of the breech at or above the level of ischial spine. The causes may be pelvic contraction, big baby, weak uterine contraction. Best treatment in such cases is delivery by the cesarean section. Both groin traction. Fingers are hooked in both the groin, and the upward and downward pressures are given. Frank breech extension by the pinard. The one hand is put inside, follow the leg of the pivot, ankle of the fetal head is hold, fetal leg is hold, and through the circle it is rotated down and pulled down. Same with the other leg. Now the extended arm. One or both the arms may be fully stretched along the side of the head or lie behind the neck. Knuckle down. The offset maneuver is used. We are holding the baby and rotated. Back is cap anterior and the rotated. First is posterior shoulder is lower than anterior. Arrest of the aftercoming head. At the brim, the causes are arrest, deflexed, contracted pelvis, hydrocephalus. Management: if the arrested due to deflexed delivery is to be completed by the malar flexion, the shoulder traction, along with the subjective pressure by the assistant. In the cavity, the causes of arrest of the head in the cavity are the deflexed head, contracted pelvis. Best management is delivery of the head by the forceps, which is effective in both the circumstances. Malar flexion and the shoulder traction may be effective only in the deflexed head. At the outlet, the causes of the arrest are rigid perineum, deflexed head, episiotomy followed by the forceps application, or the malar flexion and the shoulder traction is quite effective. Delivery of the head through an incompletely dilated cervix causes a premature baby macerated footling presentation. Hasty delivery of the breech before the cervix is fully dilated. Management: if the baby is leaving the cervix, is to be pushed up while traction on the fetal trunk is made by the malar flexion and the shoulder traction. Shoehorn method. If necessary, Drusen incision can be made at 2 and 10 o'clock position on the cervix. Face presentation. It is a rare variety of the cephalic presentation where the present part is the face. Attitude: complete flexions of the limb with extension of the spine so that the occiput is in contact with the back. Denominator is the mentum. Position: first vertex, first position, left occiput anterior become first face, right mento posterior. Left mento posterior, then left mento anterior, right mento anterior. The most common position is left mento anterior. As right occipital posterior is 5 times more common than the left occipital posterior. Mento posterior or mento anterior position. Mentum is, if the mentum is put over the sacroiliac joint, then it is a mentoro posterior. If the chin is put over the anterior iliopectoral, then it is the mento anterior. Incidence 1 in 500. Ectology: primary during the pregnancy, fetal and the maternal causes.